Hello, my name is Robin Perry and I will be presenting a global diabetic perspective for Group 9. Diabetes mellitus is a growing global concern that the World Health Organization estimates will reach 592 million people by 2035. This health crisis is largely fueled by the combination of sedentary lifestyles, carbohydrate-rich, and low-nutrient diets, and obesity. Globally, there are considerable variations in diabetes care spending, performance of care metrics, and quality of care. The provision of high quality and evidence-based care is dependent on a multidisciplinary team to deliver patient-centered care through evidence-based management of multiple diabetes risk factors and patient education. In an effort to better understand and address this epidemic, we must examine the difference in care for diabetes patients across various regions of the world and learn what we can do within the United States to make improvements in our best care models and lead the Global Diabetes Initiative. In 2012, the Affordable Care Act was passed. This resulted in a mandate of all U.S. citizens being enrolled in health insurance. More people would have access to care, and there would be more affordable options to choose from based on individual needs. There are different types of health insurance in the free market. Private insurance can be obtained through an employer. The government offers insurance in a marketplace, and there are also federally funded insurance options based on income and age eligibility. Even though there are more people who now have health insurance and access to care, this fact has not affected the growing rate of diagnosed diabetes. As of 2014, 6.7% of the U.S. population was suffering from the disease. Also, approximately 2.1% were undiagnosed. A correlation between age and number of patients has also been determined. The largest percentage of patients with this condition was 65 years or older. From the chart provided, you can observe racial differences play a role in diagnosis and subsequently treatment of the disease. These statistics represent challenges because there are many variables that can prohibit a uniform approach to prevention and treatment. Root causes. The American Diabetes Association has found that a lack of education and health insurance are root causes to developing this disease. Without basic proper knowledge and health care, a patient's physical health can deteriorate. A link has also been found between cognitive function or mental illness and the prevalence of diabetes diagnoses. The amount of preventative care a physician emphasizes affects the likelihood of the patient developing diabetes. Socioeconomic and demographic differences can pose challenges to the patient as they self-monitor the condition. It is also important to note from the pie chart that how costly diabetes care is in the country. The combined costs equal $245 billion. Quality initiatives. There are many different quality improvement activities that can occur to prevent and treat diabetes within the United States. A prevention program must become a priority to further minimize the amount of patients who are at risk for developing the disease. A patient-centered care approach will personalize the treatment based on the patient's needs and lifestyle, which can be most effective. Communication and a strong relationship between the provider and patient can also be beneficial when treating. Advocacy for diabetes should be increased due to the number of patients who have been diagnosed in recent years and the disparities among those who are treated. Hungary's healthcare system. Hungary has a tax-funded universal healthcare system since the 1930s. The system managed by the state-owned National Health Insurance Fund, which receives funding from the mandatory financial contribution of every active workforce member through the National Tax Authority. Total population of the country is covered and the insurance service is free for children under 16, full-time students, a parent on maternity leave, pensioners, and disabled citizens. The healthcare budget set by the ruling government suffered several cuts in recent years, and currently it is around 7% of the national GDP. In 2015, 700,000 adults were diagnosed with diabetes in Hungary, which is 9.3% of the total population. According to the International Diabetes Federation estimate, a further 3.7%, around 260,000 adults, live with undiagnosed diabetes. Around 90% of diabetic patients have type 2 diabetes, which is ordinary for developed countries. The remaining percentage of population deals with type 1. Chronic and untreated diabetes is one of the main root causes of cardiovascular morbidity in the country, causing nearly 9,000 deaths per year. According to the National Health Care Plan, the primary root cause of diabetes is the growing trend of obesity across all age groups of the society. The first underlying factor is the unhealthy dietary choices, mostly sugar and trans fat-rich fast foods. Furthermore, the traditionally fat and cholesterol-rich meals are now mixed with Western fast food items, creating a dangerous dietary combination for the mass. Another underlying factor is the changing lifestyle with more stationary jobs and less general physical activity by all generations. Lastly, the country's ongoing high level of cigarette and alcohol consumption is listed as a leading root cause of diabetes. The latest national diabetes program, initiated in 2011, focused on the awareness about the risks of diabetes, especially in terms of cardiovascular death. The discovery aspect is aiming to identify high-risk patients in terms of cardiovascular complications, as well as include a nationwide risk-based diabetes screening for all children and adults. The prevention component targets general population with lifestyle advices and involves active preventative techniques for high-risk patients. The overall goal of this healthcare quality initiative is to fight the most preventable root cause of cardiovascular morbidity in the country. Japan's healthcare system. This healthcare system provides a universal coverage and open access to all Japanese citizens without the need to go through the provider networks, and has fixed prices set by the government. The system is known for short wait times and low cost efficiency. As a result, Japanese citizens have high utilization rate of their health care insurance coverage. Diabetes in Japan is set to grow by over 30% to 13.5 million people by the year 2030, based on the current rate. This makes Japan one of the fastest escalating diabetes disease areas in all of Asia, Asia being overall second in growth rate to the Middle East. The majority of the type 2 diabetic population is noted to be heavily in the over 35 years old age group, as this has been naturally seen to be more prevalent in older adults. Like most countries around the world, Japan is no different when it comes to the leading cause of diabetes. The most common cause for the disease has been linked to a poor diet, such as traditional Japanese dietary staple of white rice, as well as recently emerged popularity of Western culture's fast food restaurants. It is interesting to note that white rice has been a Japanese staple longer than diabetes has been a concern. The associating factor has been growing the efficiency of the Japanese economy. As Japan emerged out of World War II with limited resources, the manufacturing industry had to figure out a way to become less competitive with resources. This continuous problem solving has led to increased efficiency and quality that was able to help rebuild the country's economy and become embedded into their culture. As efficiency grows, the need for laborious activity decreases. Mix this less strenuous way of life with the poor diet of simple carbohydrates and fast food, and you can begin to see how these two factors start to create the deadly diabetes disease. Japanese providers are standardized in how they treat and measure diabetes patients, thanks to the standardized payer system controlled by the Japanese government and the stiff competition among providers. First and foremost, physicians would recommend and educate the pre-diabetic and newly diabetic patient on proper food and nutrition as well as exercise requirements to help improve their insulin sensitivity and lower their blood glucose levels. The target after 3 months of conducting a strict diet and exercise regimen is to have their HbA1c levels equal to 6.5%, a slightly more aggressive target than U.S. physicians interviewed at the Hospital of Center, Connecticut, in New Britain, that aim for 7.5%. If the goal is not reached after 3 months, then the physician will understand if in fact the diet and exercise regimen has been followed as instructed. About 30% of Japanese diabetes patients do follow as instructed versus single-digit adherence in the US. The physician will also check to see if there are other complications present with the patient like high blood pressure, which can cause barriers to success with certain medications. Understanding the whole picture of the patient's current health status will help determine what medication to use and monitor the effectiveness of the medication in the next 3-month checkup. The Japanese government is fully aware of the growing diabetes mellitus problem and has made it a priority to help treat and, more importantly, prevent. As a result, Healthy Japan 21 was created. This policy is aimed at reducing the number of deaths of people in their prime of their life, prolong the healthy years of life, and improve people's quality of life in order to become a vigorous society in which all citizens can live in good health, both physically and mentally. From this strategic priority came the establishment of the Japan Promotion Council for Diabetes Prevention and Countermeasures, a partnership between the Japan Medical Association, Japanese Diabetes Association, and Japan Association for Diabetes Education. The Japanese Diabetes Society states that this associated cooperation has engaged over 160,000 members to date to aid in the promotion of diabetes education to the public and has established goals to reduce the number of patients and those having a high risk of contracting metabolic syndrome and to increase the number of visits for follow-up counseling. Positive results have been realized over the past decade as the increasing rate of diabetic patients have seen some slowdown. The Japanese government has subsidized these councils and associations' efforts by offering funding for providers that can help prevent the disease and achieve a 50% reduction in the prevalence rate. The healthcare system in the Middle East is different in each country. Overall, the majority of the countries follow models that are similar to the privatized healthcare model of the United States. Because healthcare in the Middle East is heavily underinvested, each country is constantly trying to develop models that are affordable. Qatar, for example, has several projects to help the diseases such as diabetes under the supervision of the Supreme Council of Health. The Gulf Cooperation Council countries in the Middle East have some of the highest rates of type 2 diabetes in the world. Type 2 diabetes has been steadily increasing in these countries, as well as the rest of the Middle East over the past decade. 9.2% of the population of the Middle East has been diagnosed with type 2 diabetes, totaling 34.6 million people. This amount is projected to grow in the future to approximately 67.9 million. Type 2 diabetes has become very common over the past decade due to lifestyle changes caused by recent urbanization. The production of oil has created a lot more wealth than ever before, something that the majority of the population was not used to. With this new lifestyle came a big dietary change. Much more packaged and processed foods have become available, as well as fast food. In the past, the majority of people in the Middle East maintained a high-fiber, low-fat diet. With the urbanization switch, their diets have now become much more high-carb and high-fat. That resulted in vast amounts of obese people. Another issue of type 2 diabetes is the limited access to care and large amount of untrained physicians. The distance to facilities is difficult for many to reach, and due to the underinvestment in healthcare, many physicians are not highly trained in dealing with diseases such as diabetes. The government has been working to focus on preventative programs as well as treatment to help those already diagnosed. In some countries, they have implemented a population health management model to help give more information on the disease. This integrates information technology and focuses on using the physicians at their highest level. There are also many different screening programs to help combat the disease, for example, Wake-Kawa. The Middle East used to help with diabetes in specialist centers. This has now changed to primary care to help prevent more people from becoming diagnosed. We have learned that the diabetes health crisis poses a significant threat to the financial and health stability of all countries, especially in the developing countries. Although evidence shows that a healthy diet and lifestyle can reduce the risk of diabetes, our social environmental factors that lead to systemic inflammation and genetic predispositions may pose a greater challenge to controlling the epidemic. Globally, diabetes evidence-based and best care treatments consistently address the issues presented in this presentation. The United States has an opportunity to lead global efforts in diabetes care through greater emphasis and support of research, increased access to care, the use of media for national public education, and implementation of standardized care protocol across the care continuum. We thank you for listening to our presentation.